So we're going to start talking now more specifically about how to actually do the assessment on patients. I'm not sure today if we'll get a chance to actually do some practicing in terms of patient assessment. We are going to learn the basic steps specifically for kids today. Remember, your primary assessment is really focused on level of consciousness, ABCs, any sort of life-threatening conditions. And it's the same for kids. You want to rapidly identify whether or not they're critical. That pediatric assessment triangle, those three things, the breathing, appearance, and circulation, those are going to help you to basically figure out, like he was saying, critical or not critical, sick or not really all that bad off. If they fall into that critical or super sick category, you need to go ahead and start with transport right away, because as soon as you know they're critical and as soon as you can get them somewhat stabilized, get them in the ambulance, go to the hospital to try to get them a higher level of care. So with any assessment, you have to form your general impression first. And again, that's that pediatric assessment triangle, sick, not sick, critical, not critical. That's really all a general assessment is. It's at the most basic level. When you see this person, do you go, oh, okay, we're good. That's that whole stay and play thing. Are you good to stay and figure out maybe what's really wrong? Or is it one of those, oh crap moments, we got to go now, because there's really something about to happen with this person. When you're assessing mental status, you got your AVPU. You can do that with kids as well. Like, you can classify it the same way. Just be aware that they may not respond the same way. So when we talk about verbal, you may have to raise your voice a little bit more or do a little bit more to get their attention, just because, especially depending on how old or young they are. If there's somebody that's used to hearing speech, like they go to school and maybe they're used to listening to adults, that's different. But if they're a baby, you may have to make a little bit more effort to get their attention, just because they're not really necessarily tracking and all that stuff yet. 3-month-old infant is not necessarily going to respond to loud noises the same way that somebody else would. When it comes time to check and see, like, if they respond to a painful stimulus, do not shake or anything like that, especially to a young infant. So what we do to adults, where we kind of like shake their shoulder, don't do that to a baby. You want to tap them. Tapping them's fine. Pinching, kind of like on the hand or like the cords of the neck, that'll be okay as long as it's done not with an intent to really harm. But you don't want to shake, because remember, the neck is really, really fragile. Shaking the body and the neck might go like this, and that's not that great for anybody, but really not for a baby. If you are assessing their airway, you do it the same as you do with an adult. Remember what we were talking about, the anatomical differences in terms of how the head is, how the structures in the head are, to be aware of opening that airway. So you may need to put a folded up towel or sheet underneath their shoulders, kind of lift their chest a little bit so their airway's more open. You want to make sure their airway is open, though. Remember to suction, or be aware that suctioning might be necessary. Kids, especially younger kids, even like infants, if you've ever dealt with kids in any real, in anything, if you babysat or whatever, you know that kids aren't very good at wiping their noses or clearing away their face or anything like that. They make a lot of mucus and they don't ever really deal with it usually. So be aware of that. Be aware there may be more mucus than you might expect with an adult who knows how to like blow their nose into a tissue. Remember your CPR. Again, with airway, you just always have to be concerned. Okay, when you're assessing breathing, we've kind of talked about this, that some of the things you might see. Altered mental status goes along with any person who might be in respiratory distress. But we do look specifically for those flared nostrils, like really wide open nostrils. The pale or bluish lips or mouth, again, kids' circulation, it really tanks really fast if they're not breathing well. So you're going to notice that bluish tinge a lot quicker in kids than you do in adults. Stridor, grunting. Remember what stridor is? It's one of those, it's the noise, kind of a crowing noise, I guess, that happens when the airway is obstructed somehow. It's like air whistling past some sort of obstruction in the airway. This isn't what it sounds like, but an extreme example would be, if you take like a balloon that's full of air and you like pinch out the sides of the opening, like if it's not tied off yet and you can hear the squeak as it comes out of the balloon. Do y'all know what that sounds like? Okay, nowhere near that extreme, but it's that idea of air is forcing its way through a much smaller opening than normal, and it is making kind of a weird noise. You're going to notice increased rate of breathing for a child who's in respiratory distress. We talked about retraction. Decreased muscle tone is going to kind of go along with potentially not getting enough oxygen, that your body just doesn't work as well. You kind of go limp. Use of abdominal muscles, we said kids do this sort of anyway, but if you see a lot of that and you see the retractions and other stuff, that's a good sign that they're having trouble breathing. When you're assessing circulation, we talked about this. You can assess for pulse like normal. Remember for kids, or at least for babies, what pulse do we use? Brachial is probably your best bet. You won't necessarily find this as strong or as well as you would in an adult. And this is hard to get to sometimes depending on if they have a neck or not, how young of a child they are. Fat little necks. But brachial pulse is usually fairly easy to find on babies. Next time you have an opportunity to hold a baby, if that happens for any of y'all, try to find the brachial pulse. You might be surprised. You can probably find it on yourself, but it's actually substantially easier on a baby because they don't have as much like muscle and stuff built up around the area. Like I was saying, that the capillary refill is really good for assessing circulation in babies and young children. So that's what they're showing here, except with the whole hand. And that works as well, just to show how is circulation going. Y'all know what capillary refill is showing, right? Like you're pressing all of the blood out of an area, and then you want to see how quickly the blood comes back into that area. That shows whether or not they have good circulation. Okay, so identifying priority patients. The priority patient is the one that is having respiratory distress, altered mental status. The patient that you look at based on that patient, the pediatric assessment triangle, and you go, oh crap, something is really, really wrong here. We need to get them to the hospital. That's your priority patient. That's the one that you transport right away.
The baby looked fake.
The baby, it looked fake.
What? It looks fake.
He looks, I'm assuming I don't know.
Like the neck up, like the neck and the head.
Oh, yeah, I don't know. I mean, I think that's probably just the angle.
It looks fake.
Okay. So, for physical exam, for a pediatric patient is not really quite the same as you would do for an adult. So adults, when we do our physical exam, we work head to toe. It's just easier to have that system to start from what's up here and work down. It's also convenient because the things you're expecting to find the most problems with would be in the head area. I mean, those are the most vital issues. So if you check head, scalp, brain, spine, everything first, you're checking the vital stuff first, and that's a good way to go. For kids, you don't want to get around their head right away. It's one of those things where it's going to freak them out. You want to kind of start a little bit slower if you can afford to. If they're a priority patient, you do what you have to do. But if you can afford to spend the time to do a physical assessment, spend a little bit extra time, you want to start with the non-threatening parts of their body, which would be parts that are farther away from like what they see, their face. So starting with their toes, working your way up their body, essentially, starting with something that isn't a big deal, that they can kind of get used to. Okay, he's touching my toes. Okay, my feet. Okay, so it's like it starts with something easy, not as threatening, and then work your way up. So by the time you get up towards their chest and their head, they're used to this idea that you are touching them in a way that feels okay already. If there's no injuries, it would be ideal for the parent to be able to hold the child, especially if the child's very young. A car seat would work as well. Something that can kind of help hold them still. If they're young and they're not used to holding still, or if they're an infant, it's going to be a lot easier if you've got somebody around them kind of holding, comforting. Protect their modesty. Babies couldn't care less if you take their clothes off. They're used to it. But anything about age 1, even starting from that toddler age, they're taught very, very quickly that you don't take your clothes off, except for things like going to the bathroom and taking a bath and things like that. So for them, if you just start taking their clothes off without realizing that modesty is a thing for them, it makes them very, very uncomfortable. So you want to go ahead and try to protect that modesty by only remove the clothes that you have to, lift up the shirt to check the belly button, and say, I'm going to look at your belly button, okay? And I'm going to see how that looks. You can check their abdomen, and then you can put the shirt back down, and it helps them feel safer. You want to go ahead and explain why you have to remove or move a piece of clothing. You don't always have to just say, I'm going to check your belly button. Like, you can tell them specifically, I'm going to be feeling around your belly to see and tell me if you feel anything that hurts, okay? Depending on the age, you can talk to them. But you do want to explain things as you go, like with equipment, like with everything you do. Explain what's happening. Make it a little bit easier for the kid to understand what is going on. Okay, so there are some special concerns in pediatric patients specifically. We talked about this, maintaining an open airway. You want to use that head tilt chin lift You want to try to support their shoulders a little bit to keep that airway open. Suction, like I mentioned, and check for that tongue again, because the tongue is, like I said, relatively larger, so you want to make sure that that is a special consideration. Remember, y'all know how to use your OPAs and your NPAs. Don't use them unless you have to. You can't use the OPA if they've got a gag reflex, but just be aware that you may need to be especially considerate of the tongue. If you have to give oxygen to a young child, you want to be careful how you give it. So we talked about like start somewhere non-threatening when you're doing the physical assessment, because getting it near the face is a concern. Same thing with the oxygen. You don't want to like just stick something on their face. They're probably not going to tolerate. They're going to take it off. They're going to scream. It's not going to do them any good if they're screaming and pulling it away from their face. So you want to try to find a way to give them oxygen that is not going to be threatening. One good technique for this would be what we call blow-by oxygen, which is essentially just to hold anything from oxygen tubing to a mask or whatever, hold it up right next to their face or kind of close to their face. And as the oxygen's blowing out, hopefully they're getting something. As they're breathing, they'll breathe the oxygen that's kind of pouring out into the area right around their mouth. And they'll be getting more than what would just naturally be in the air anyway. Wouldn't be as good as having something on their face, but if they won't tolerate having something on their face, this is your best option. Some services, I've seen these, they're kind of like foam bears or other toys that have actually a place where you can like plug the oxygen tubing into the backside, and then the front has like vents on it. And so if you plug that into your oxygen, the oxygen actually is coming out through the bear's like chest or whatever. And as the kid's holding the bear, you give the kid the bear to hold. As the kid's holding the bear, the oxygen's coming right up in their face. So it kind of is a twofer. It gives them something to hold on to, be comforted by, and it's giving them oxygen as well. Be aware that if you do have to use a child's face mask, you need to use a child's face mask. Anything larger is going to engulf their head. Like if you use an adult one on a little baby, it's just ridiculous. Way too big. Okay, so pediatric patients, we've talked about how they are more susceptible to stuff going wrong. They're not as good at adapting. One of those things we have to be concerned about is shock. They can become dehydrated a lot quicker through diarrhea or vomiting or stuff like that. That can cause shock really, really easily. Hypovolemic, their volume of blood in their body goes down because the liquid overall in their body has gone down because they're so dehydrated. Infection, it can happen to adults, but it can definitely happen to kids. Trauma can cause it. Blood loss, same thing with the dehydration. Allergic reactions, they're really, really prone to. Poisoning happens a lot more for kids than it does for adults, at least accidental poisoning, because kids put everything in their mouths, and if it looks tasty, they want to try it. So that's why I think I went over with y'all about the poisoning sections, the Mr. Yuck stickers. Did we talk about that in this class? Mm-hmm. Okay. But kids do put everything in their mouth, and they are much more commonly accidentally poisoned. That can cause shock. Even if it's not only does it take less of a poison to hurt a kid than it does an adult, but their bodies are just less able to stand up to whatever. So it's rare for a kid to have a cardiac event all by itself, unless they have some sort of heart defect that probably their parents know about. Not always, but usually. You're not going to expect just a sort of a spontaneous cardiac arrest in a kid, because their heart muscles are still pretty good and young and fresh, again, unless there's actually already a problem. Okay, so things you might see as far as shock goes in pediatric patients, because they won't necessarily present the same way. Altered mental status, as much as you can tell that based on how maybe they should be acting at that age. Pale, cool, clammy skin, that's a classic shock sign. Absence of tears when crying. Why would this be potentially a sign to look for with shock? Say that louder.
The babies always cry when they need something.
Okay. But remember, we also talked about ways they can get dehydrated easily, right? Okay, so if they're crying, or if they're making the noise and they'll look like they're crying but no tears are coming out, that is also a good sign that they're dehydrated. And since dehydration can quickly lead to shock in babies, or more quickly than in adults, it's a sign if you're not seeing tears but you're seeing where there should be tears. Yeah, it may totally be the kind of thing where they're crying and it's just like noise, but not tears kind of crying. But you may also need to consider that it could be a sign of dehydration, which could lead to shock. For kids, you're also going to see falling blood pressure, just like with any person with shock. Delayed capillary refill, because that's that circulation going down. Rapid or weak pulse, rapid respiratory rate. And then that apathy or lack of vitality. We've talked about the lack of muscle tone, just not seeming as active as they were. These are all things that essentially will tell you something is really wrong with this kid when you're doing that pediatric triangle thing. Remember we talked about how kids have more surface area compared to their volume than adults do. So they're much more likely to lose their body heat quicker. You want to make sure to really protect against that. Not just with shock patients, but with any patient that's a pediatric patient. Keep the compartment warm. Try to cover their head, their body. Keep them warm with blankets or their clothes or something. If they are potentially in a hypothermic situation, like if they've actually been outside and gotten really, really cold, you want to be super careful in terms of how you're warming them up. Talk to medical control, because for anybody, too much active rewarming of a patient who's had extreme hypothermia can actually send them into cardiac arrest. If you do it too quick, too much, all at once, it shocks their body, shocks their heart. Even more so with kids. So if you have that situation where a pediatric patient has been very, very, very cold, and you're trying to warm them up, you want to be extra cautious about it. Don't roughly handle them. Don't put them in like a bath of hot water or something like that. It needs to go slower than that. And you probably need to talk to medical control to make sure you're doing it right, because they're so sensitive to that kind of thing. We'll go a little bit longer. Okay, so pediatric emergencies that you are likely to see. Respiratory, one of the most common. If they're going to have a heart attack, it's probably because a respiratory problem came first. You want to try to do your best to diagnose maybe where the problem is. It can be an upper or a lower. So if it's an upper airway problem, it may be something as simple as choking or partially choking on some sort of object. It may be an actual medical disorder. They've got asthma or they've got something else. You don't really know, but you want to kind of try to see if you can tell which side it's on. And that may help you understand what you can do to help that person. Because if you think it's upper airway versus lower airway, you act slightly differently. We've already talked about this, the things that you're going to see and hear with breathing difficulty. We've listed literally all of these things. Same with these, really. If it gets to the point where the heart rate is decreasing, it's a real concern. Kids are pretty adaptable. Their bodies will work hard to try to deal with stuff. Like I said, they can only compensate for so long, but their bodies will try. If they get to the point where the heart rate is decreasing, it's a real concern. You're looking at a problem that may end up to be deadly. Let's see. You'll hear that noise, the breathing. Okay, that like weird high-pitched noise, that's the noise of the baby's breathing every single time as they're trying to breathe in and out, because there's some sort of obstruction or swelling of the airway that's making it really hard for air to get through. Poor baby. Okay, croup. Do y'all know what croup is? Okay, it's another respiratory disease. I'm assuming this will show like a slide of what it looks like or sounds like. You can see those retractions. Okay, so again, it's that noise mostly on the inhale as some swelling in the throat that goes along with croup is making it really, really hard for the kid to inhale and then exhale. Epiglottitis, what would this be? Yeah, that's just vocab. Inflammation of the epiglottis. That little piece in the back of your throat that flaps over to make you stop from swallowing food. If this happens, it becomes enlarged. It's very difficult and painful to swallow. Kid's going to be drooling a lot. And I'm assuming this will show you what they sound like.
A 47-year-old woman came to the emergency room complaining of a sore throat, fever, and difficulty swallowing. Urgent otolaryngology and anesthesia consults were requested. Fiber optic examination of the larynx confirmed our suspicion of epiglottitis. Notice the swelling and inflammation of the epiglottis and surrounding tissues. The epiglottis is reddened and has become rounded. Epiglottitis is a life-threatening condition that can quickly and unpredictably lead to complete airway obstruction. Epiglottitis can occur in any age group. Frequently, there is inflammation of the surrounding tissues, including the tongue, vallecula, and our epiglottic folds. This has led some to call it supraglottitis, which better describes the disease process. Signs and symptoms alerting impending airway obstruction include respiratory difficulty, stridor, drooling, and aphonia. Lateral cervical soft tissue x-rays can be a sensitive indicator of epiglottitis. However, normal x-rays do not exclude epiglottitis. When facing epiglottitis, one must be prepared at all times to establish an airway, non-invasively, such as with conventional endotracheal intubation, or invasively via a tracheostomy or cricothyrotomy. An otolaryngologist should be present whenever possible. When respiratory distress is present, intubation by an experienced anesthesiologist is usually required. Stable patients without respiratory distress can be managed without endotracheal intubation, but they must be monitored continuously in an intensive care unit.
Okay, I hope there's no more videos in this particular slideshow. When you are looking at altered mental status in a child, try to figure out what caused it. Look for signs of shock. There's a good chance that this is a poisoning issue. Poisoning, seizure-related disorder, respiratory to some degree. You want to be aware, if you're seeing altered mental status in a kid, you want to be looking really on the lookout for these things. Because it's not super common. They're usually not going to get to this point. So if it happens with a kid, I mean, there's just less options for it to happen with the kid. You're not going to be seeing them usually getting into the liquor cabinet or something like that you might think of as leading to altered mental status. So when it happens, it's sort of more of a concern. If you have a kid who you suspect there's been poisoning or you know there's been poisoning, you want to look for any signs of poisoning, which would be potentially something around the mouth, some residue or potentially any sort of thing that might look like a blister or a chemical burn or something like that, depending what they swallowed. You'd want to try to figure out what it is that they swallowed, how much of it, if at all you can. You want to try to figure that stuff out. You're going to contact the Poison Control Center. The only thing you can really do for it is activated charcoal. But what are some contraindications for activated charcoal? Do y'all know these? Y'all have gone over your drug cards, right? Yeah, probably a long time ago. But what can you tell me would be some contraindications for activated charcoal? Say more? Okay, unconscious because they can't swallow. What else?
Is it like a certain period of time?
Potentially. I wouldn't usually use that as a reason not to give it. There's one that I'm definitely looking for. Okay, yeah, breathing potentially. Remember I mentioned you're looking for something around their mouth to see if you can tell what they took. If it looks like what they took might have been something caustic, corrosive, toxic, that would actually cause harm to the respiratory tract or the digestive tract, you don't want to try to make them throw that back up. So if they drank bleach or something and you can actually see a little bit of the chemical burn on their face, you don't want to try to make them throw that bleach back up, because if it hurt once going down, it's not going to hurt any less coming back up, and it might actually make the situation worse. So for caustic, corrosive type chemicals, you don't want them to have activated charcoal, because the whole point of it is that it binds to whatever's down there and makes you throw up to try to get rid of it, get it out of your system. If you suspect poisoning alongside charcoal, really all you can do is the oxygen and the transport, and just try to get them somewhere as quickly as possible that can deal with poisoning. If they're unresponsive after a poisoning, now obviously you wouldn't give your activated charcoal all you can do is that airway, oxygen. Be prepared you may actually have to ventilate at this point if they're at the point where they've actually become unconscious, and try to transport them right away. We're going to take a break here real quick. Okay. Drowning. If you have a pediatric patient who might be drowning, you kind of deal with them the same way that you would for any patient who might have drowned. Artificial ventilations or CPR, airway, spinal immobilization. Why spinal immobilization? Why is that a potential thing to worry about with drowning?
Because you don't know if they fell into accident.
Yeah, I mean, it could be anything. It could be that, like, they knocked against something and hurt their spine, and that's why they fell in. They could have tried to dive in and hit their head on something, whether in a pool or in some other body of water. You don't know. You don't know what's down there. You don't know what they hit themselves against or not. So you would want to consider that. Hypothermia, we've talked about why kids especially, but also obviously if they fell into water, you can guarantee they're losing some body heat. Even if it's relatively warm water, they're losing some body heat. Unless they're swimming in water that is 98.6 degrees, it's going to be cooling them down. Treat any trauma that you see, transport. Same things you would do with any drowning patient or patient that might have been involved in a near drowning. Sudden infant death syndrome, or SIDS. This was a really big deal. I don't know that I've heard much about it in the news recently, but like 10, 12 years ago, really huge deal. Because we don't know why it happens. Babies just die, usually overnight or something like that. That has often been in their sleep. We don't know why. There's no real cause that we can find. If you are called out and it appears that this may have happened to the child, that they are unresponsive, and by all things that you can see that they may actually be dead, you'd still treat them as if they're alive. This is with any patient, not just pediatric patients. You treat them as if they're alive by doing CPR, the rescue breath, the whole thing, because it's not up to you. You can't actually pronounce death. So you wouldn't be the one to say, oh yeah, no, he's gone. You'd want to go ahead and try. Also because for the parents, it's a very traumatic thing. They'd rather see you trying something. So you would resuscitate, or at least attempt to resuscitate, unless there are those obvious signs of death, rigor mortis, decomposition, the settled blood, that lividity of, like, obviously they've been dead for a long amount of time, stuff like that. Your real concern here is the emotional support of the parents. If the child is dead at that point, the people you are treating is mom and dad or whoever, because they're the ones that need you at that point. Baby, you can't do anything about the baby. Yeah?
For rigor mortis, how would you be able to tell?
Rigor mortis, remember, is that stiffening of the muscles. So, like, the way it works, basically the muscles get locked into a position. I don't know if y'all know much about how the physiology of muscles works. This morning I sat through Randy teaching cardiac physiology, and he went over this in a lot of detail, but I know it's been a while for y'all. Basically, the way muscles work, it's like these fibers kind of lock onto each other, and that's how your muscles actually contract, by locking and then releasing, and by the calcium and other things are involved in that process. Rigor mortis is just when they lock on, and then a signal is essentially never sent to release. So all the muscles lock, and everything is stiff. And the only way it becomes unstiff 12 to 24 hours later is essentially enough decomposition has happened that those bonds that were locking have loosened and relaxed. So that's what's happening. Their muscles are all tensing at the same time, sort of, or stiffening in the position they are, I guess is the better way to put it.
And what about whenever all the blood goes to...
The lividity, that's just the force of gravity. Since it's no longer being actually pushed through. It's going to be fairly rigid. Is that what you're meaning? Like with the blood? Yeah, it'll be filling all those tissues. So it'll be, I don't know, like you can press into it, but it will be fairly firm, I guess, is all the way I can think. And when you press into it, it doesn't spring back out like how living flesh does. It stays pressed. And you can usually see like a lighter spot where you pressed, kind of thing. Okay, if there's a trauma emergency, go to a pediatric center. Pediatric patients go to pediatric centers. They just know how to deal with them. They have the equipment required. They have the extra knowledge required. They've specialized in it. They're designed for pediatric patients, so that's where you go. Dallas, we're pretty fortunate to have quite a few places. I mean, we have a lot of hospital-type options here in Dallas. We've got several, though, that are really great. Children's Medical is the big one for kids. They deal with most of the stuff here. So go there. Go to the pediatric place. Okay, things to look for in like injury patterns. So things you would specifically see with pediatric patients involved in trauma. During motor vehicle collisions, remember, with an adult, what are you going to be seeing? Like say they're the front side driver, or excuse me, the front seat driver. What would you be seeing as far as injury patterns? Potentially. If they have a head-on collision with something, what might you see?
The window broken or something in the steering wheel.
Okay, so like on the patient, what would that end up looking like if you were just looking at the patient? Okay, so you might see some head trauma, maybe some crack, something from it hitting the windshield or something like that. What else? Anything else you can think of? Chest, right? You got the seatbelt that might have been there causing some sort of mark. Remember, they're thrown into it, okay? The steering wheel might have done something to their chest. We talk about these patterns because that helps you figure out what to look for. So, steering wheel. Airbags, potentially, might have caused some sort of burn, like friction-type burn on hands, arms, face, something like that. So you might be on the lookout for those. What else? What if they're thrown really hard forward and like their knees hit the dash? Okay, abdomen, sure. Also, you might even see like broken legs, broken femurs, especially from that real hard impact. Knees hitting, okay, crunching forward, that femurs might break. What were you going to say? Okay, yeah, neck, the whiplash for sure, or even something more severe. So these are things you would expect if you knew that there was a front-on collision with when the person in the driver's seat was your patient. These are things you might automatically say, okay, I'm going to check for skull fractures and neck I'm going to assume neck problems, and I'm going to look for legs, abdominal, chest, bruising, all that stuff. That's what you would look for in a patient.